All right, hi everybody. It's Dr. Chrissy from NGI Omics and SNPED. I have my team here today, and we are going to be doing a GeneBite on oxalate sensitivity. So I'm going to introduce everybody. I've got Laura Kelly, and I have Michelle Godfrey, and I have Samantha Venz. And Samantha did our GeneBite on oxalate sensitivity, which I'll put in the comment boxes below this once I post it on social media. But we are going to be hanging out with you today, as usual, like we do with all of our GeneBites, which one day maybe we'll be like the cool kids and have a podcast and do this. But today, like I said, we're going to have a quick little presentation for you guys and just kind of go through what oxalate sensitivity is and kind of show you the do's and don'ts and what causes it, and talk about oxalate diet or low oxalate diet and just how we do that here at NGI. So I'm going to go ahead and start the presentation. So give me just a second. Sometimes it takes just a second to kind of get that going in terms of the slideshow. There we go. All right, and so since Samantha did our GeneBite, I'm going to go ahead and have her start out with the basics of what oxalate sensitivity is. So Sam, why don't you go ahead and take the show?
All right, so oxalate sensitivity is probably one of the most common issues that we see with our patients. And a lot of times they have symptoms that have not been attributed to any other foods or any other issues. So a lot of times figuring out that they have problems with these oxalates, it's kind of like a light bulb for them. So essentially what happens if someone is eating a very high oxalate diet is those oxalates are binding to calcium in the body, and then they create deposits or crystals. And where those crystals deposit often influences the symptoms that that patient experiences. So for example, they may have urinary symptoms like interstitial cystitis, chronic UTIs, kidney stones is a very common one that we see. They may have neurological symptoms like anxiety, depression, irritability, brain fog, and they may even have skin issues like itchy scalp, burning or tingling in their skin. Some people even develop what looks to be rice grains underneath their skin because those crystals are accumulating underneath the skin. So it can be any variety of symptoms, and depending upon the person, it can manifest very differently. So what foods are the highest in oxalates? So we have the big four that we often tell people about, and those are often the foods that we start with. So it's going to be wheat, nuts, soy, and spinach. Also, some other higher foods are going to be things like sweet potatoes, celery, and everyone is on the celery juice train, which now we see may not be good for everybody. Again, everything is individualized. Berries can be high. Huckleberries and blueberries aren't as bad as strawberries and raspberries, for example, so it varies a little bit depending upon the food. But there's a lot of education involved in this because so many of these foods we've been told are very healthy and can do a lot of good for our bodies. But if someone has the genetic propensity or metabolomic propensity to have issues or reactions to these foods, then it can clearly cause a lot of issues for them.
Yeah, that was great, Sam. Thank you. So one of the things that I created years ago was a point system for my patients. So as we look across a lot of the literature out there, it can be really confusing. So when people kind of go and they go, man, I've heard of lectins or I've heard of oxalates, and they go to Dr. Google and they go, man, I think I have this issue, or my mom had a kidney stone, so or maybe they've even gone to their nephrologist or their urologist, and they go, man, I think I have this problem. And they, put themselves on a low oxalate diet. They may go to, one website, or, Harvard may say one thing and Mayo may say another, in terms of what a low oxalate diet actually is. And so, I had created a point system that I thought was pretty easy. And, as I grew, from a primary person, to a larger practice, I kind of figured out that there were, different types of people in the world. Some people really like to have a point system where it's, kind of easy and they don't have to think about it or number crunch. And then there are other people that really, really like to have, milligrams. And so I have, two different people here that work for me. One has an accounting background. Michelle has an accounting background, and so she happens to like milligrams, and a lot of her clients and patients really like milligrams as well. And then Laura is got a background in psychology. And so, a lot of her clients and patients really end up liking to have that more maybe feel-good perspective of not necessarily having to number crunch. And so I'm going to kind of toss it over to those two for a second and let them talk about their experiences and dealing with this type of diet that kind of takes all of the so-called healthy superfoods that everybody's learned to love and appreciate and kind of turn it on its head.
Yeah, so often when I work with people, there's a lot of fear around changing their diet. And so then, just talking about the point system a little bit, it tends to take some of that fear out of it, in part because it's not so strict, it's not so strict or number based. Which I know and Michelle will talk about, how that helps some other people. But typically what I do with people is I do take out the big ones and we kind of leave it there, and we'll talk about oxalate dumping a little bit later, but not trying to pull out too many foods too quickly and getting people used to those kind of basic changes first. And then we work on that point system where, it's a little bit more loose. And so it feels, a little bit easier than maybe having to calculate or count up, all of those oxalate milligrams every day. And so you're really just counting up to, 6 or so, rather than really trying to find like that 50 to 60 to 70 milligram amount and having to remember that. So I find that tends to work a little bit better just from that kind of perspective of, like Chrissy said, sort of the feel good perspective of, this isn't so hard after all. But then there are other people, as Michelle will talk about, that do like it to be much more exact, and that feels more comfortable and safer for them.
So the goal is to get out these foods. And I think some people, when they see that spinach has 700 milligrams for 1 cup, and let's say some pepper on your food has 10 milligrams for, to me that they're like, oh, well then, maybe I can have my 3 favorite foods for the day, and that does equal 50 milligrams instead of, it's just a different way of looking at it, and it just depends on your personality. So for me, again, I like spreadsheets. I like, adding things up, and for me that works perfectly. I know almonds and spinach, they're not even going to be in the equation because they are over 50 milligrams per serving. A low oxalate diet is, in the literature, is really under 250 milligrams a day, but for people who have hyperoxaluria type 1, I like to see them under 50 milligrams. Half a cup of French fries has 50 milligrams of oxalate. So it just depends on how you want to look at it. So you can do it either way. And the point system works well because you just say, I'm going to eat 2 higher oxalate foods a day, or I can have 3 medium, or I can have as many low as I want. And that's a pretty simple way of looking at it.
Exactly. So that's why we have the 2 different approaches at NGI. Because we have the ability to pretty much make everybody happy. So, if there's, if somebody really wants to have, if there are, somebody really, really likes a certain type of food, like their favorite food, and it happens to fit within the milligram or the point system, we essentially can accommodate for that. And depending on their genetics, or depending on, where they fall in terms of that scale. The big thing is making sure that, and this is something that they often teach in master's programs or doctoral programs for nutrition, is meeting the patient where they are. Because if you're not going to be compliant, anybody know what chocolate is, like a square of dark chocolate in terms of milligrams? Is that anybody?
3. It's 3 points.
Yeah, 3 points.
So it's higher.
15 or 20 milligrams.
Yeah. 20, yeah. So, for a lot of ladies out there, There's that, I really, really have to have my chocolate kind of girl out there. Not me personally, but Samantha's a chocolate kind of girl.
I haven't done my testing yet because
right?
I don't want to know.
Right? Sam does not want to know what her oxalate status is.
Nope.
So, because there are, certain people that go, man, I'm not ready to give up that chocolate habit per day. So, those are the kinds of things, but let's just say Sam maybe does have an oxalate issue. If she had to be under 50 milligrams of oxalate per day, then if she still wanted that 1 square of dark chocolate, then we could accommodate for that. But, we'd have to be really, really careful about the other oxalate foods. So just to kind of give everybody an idea of what, an oxalate diet looks like. So we're going to move along here and talk about what exactly hyperoxaluria is. So this is more of the scientific approach, the genetic approach. So we're really looking at an enzyme here. It's called glyoxylate aminotransferase. This is an enzyme in your liver, and this catalyzes the conversion of something called glyoxylate to glycine. This does have a cofactor of vitamin B6. And so, for my clinicians that might be listening out there, we probably would expect them to have low levels of glycine. And if you're looking at metabolomics testing, the marker that we look at for vitamin B6 is called xanthironate. So you would want to be validating or looking for these things to determine, man, does this person have this? And then if you're also going to be looking at genetics, we're going to talk about that in just a second and look at all the genes that would be associated with this. So if you have issues with this, then what ends up happening is that you have calcium salts that start to accumulate in the kidneys and other organs and other tissues. So the problem is that the kidneys, these are our filtration organs, okay? So if they are, I kind of describe oxalates like shards of glass. When you swallow them, they rip through your esophagus first, okay? They shred through your intestines, and they poke holes there. So then we get leaky gut to begin with. Then once they get into the interstitial space, then they have to get filtered through your portal system, through your blood system here. Then once that happens, then they have to get filtered through your kidneys, of course. But along the way, they end up getting deposited in other tissues, like your muscle tissue or your brain tissue or your bones or those types of things. So, but when we're talking about genetic hyperoxaluria type 1, you're going to know pretty early in life. So you're going to end up having these calcium deposits pretty soon. So oftentimes before, the age of 30, most of the time you're going to end up having these kidney stones. I've had 2 children by a natural childbirth and a kidney stone, and I would rather have the 2 kids by a natural childbirth again than have a kidney stone. So this is something very personal here at GeneBites. We talk about all kinds of fun stuff here, but do not recommend getting a kidney stone. So this is something that we're talking about here for type 1 hyperoxaluria. All right, so if you want to get a diagnosis of type 1 hyperoxaluria through a nephrologist or a urologist, you're going to be looking at elevated oxalate to creatinine ratio in your urine or elevated plasma oxalate concentration. Okay, so this is not looking at functional testing. This is with your nephrologist here. You also want to be getting a genetic test looking at the gene AGXT through molecular genetic testing. We do have a SNP table coming up next, don't worry. If you do not have genetics for this, they're going to want to do a liver biopsy. And a lot of people are like, oh, where do I sign for that? Yeah, nobody really wants to do that. That's not fun because that's, a very invasive sort of procedure here. And they're looking at the enzyme that we spoke about before, the alanine glyoxylate aminotransferase. Aminotransferase should sound familiar. Alanine aminotransferase, that is, again, a liver, very similar to your liver enzymes like ALT. So those are things that you should be thinking about. They also have the cofactor of vitamin B6, just like our liver enzymes. All right, here are our genes for genetic hyperoxaluria. So the one that we've talked about so far is AGXT. This is genetic hyperoxaluria type 1. This is the causative variant here. What we haven't talked about so far is hyperoxaluria type 2 and type 3. Now I have listed the SNPs here for you. What I'm going to do now is I'm going to ask my team members to kind of chime in here, and we're going to talk about what we do in terms of treatment and intervention when we see these different variants. Because there's not a whole lot of literature in terms of genetic hyperoxaluria type 2 and type 3. And in terms of testing and validation, Great Plains Laboratory actually assays these directly, and looking at things like oxalate concentration and glycolic and that kind of thing. It's a little bit outside of the scope of what we're going to talk about here today, because this is more for patients and not necessarily for clinicians. If you're interested in learning about that, if my clinicians are listening, please come check us out at SNPED. Guys, what do you guys think about, what we would do in terms of like point systems and diet interventions? Let's say we don't have any issues in AGXT, but we have issues in type 2 or type 3 SNPs.
So 2 and 3 are a little bit less invasive. So if we see a bunch of SNPs that have one variation, we may let you have a little bit higher point value in your diet, whereas if we see a yellow or a red in AGXT, we're always going to have you be low, because that's what causes kidney stones. The other two are more involved with depositing in other tissue in the body. So poking eyes, you'll have, sometimes autistic kids have the sore eyes. I find people get a really sore scalp, fibromyalgic type pain, maybe some buildup of crystals in the shoulders. So the 2 and the 3 are those types of things that are a little bit harder to say. Like you don't have a kidney stone, you just have other symptoms, and it's hard to know. So that's why looking into genetics is super important. We have all of these genes on our optimal diet panel, so you'll know, and we'll be able to help you. We'll explain it to you if you have it.
I do find that these two, there's much more sort of symptom that goes around with it, meaning, that you can almost feel it if you eat too many oxalates. Yeah. So that comes out more quickly, that feeling comes out more quickly if you make the mistake and go over the point system that you have. Where the AGXT, like you don't necessarily know when you're going to have a kidney stone. It takes a little while for that to build up in the system. And so we're usually catching that like later, or diagnostically you're catching it later, where the other two seem to be almost like you can literally feel it.
Yeah, I've had people say they eat and then they literally immediately have shoulder pain.
Yeah.
So it's, if you really know what you're watching for and you realize you have this, I think you'll be more aware of what's going on in the body.
Yeah. And fibromyalgia is the same. I think it's similar to that, is that it literally, the pain will it'll feel like you have the flu. I mean, it just feels, you really feel it. Yeah, which is good, because then you've had the experience of taking the foods out, and then you make the mistake and eat, and then all of a sudden you're like, okay, well, that's why I'm on this diet, and just reinforces the benefit of doing what you're doing.
So there's there are actually 2 other genes that we look at on the optimal diet panel that we have at Omics. And the one in particular that I'm thinking of is a vitamin C transporter that increases the absorption and transport of vitamin C. And so, one of the things that we do when we have genetic hyperoxaluria of any type is we actually restrict vitamin C intake. And so it's especially salient when we have errors in AGXT or genetic hyperoxaluria type 1. We actually restrict vitamin C intake from food and supplementation to no more than 200 milligrams per day, because if you cannot, it increases the absorption of oxalates. But if you have this transporter issue, you really have to be even more careful about the intake of vitamin C. So, it's really interesting, because a lot of people, have this thought process about genetics. Okay, have this one gene, it equals this. But we're really talking about what's called polygenic. We're looking at multiple different genes, multiple different markers, and how they interplay. So it's just one thing, it's one example of how I wanted to kind of talk about that at this moment here. So, but thank you guys for talking about that and how we change the system here. Genetic hyperoxaluria type 3 is obviously not as penetrant, or it's not as bad as type 2, and type 2 is not as bad as type 1. But we do have some other interesting associations when we talk about other influences. I've got a little treat here at the end for people who maybe have connective tissue disease or who've maybe been exposed to fluoroquinolones. When we think about kidney stones, we're thinking about it being not as bad, but it turns out that people that have genetic hyperoxaluria type 2 or type 3 actually have a greater predisposition to having damage from fluoroquinolones. So those are drugs like Cipro and Levaquin. So, even though, we think about them, and you see 1, 2, or 3, you automatically think it being, okay, well, this isn't as bad. We actually kind of have to flip that script a little bit when we start throwing in other environmental exposures, like, previous history of antibiotic use. All right, so we've talked about this a little bit. What does it look like in terms of what happens if you have any of these conditions, genetic hyperoxaluria 1, 2, or 3? So I think I'm going to let somebody else talk about this. I think I'm going to let Sam talk about this. So Sam, what does it look like?
So as I mentioned before, depending upon the person, oxalate crystals may be deposited in many different tissues or organ systems within the body. So they can be deposited in the bones. So you want to make sure that you're checking your resorption markers such as proline, hydroxyproline, and hydroxylysine. And if this has been going on for a long period of time, if they have been consuming a ton of oxalates for a long time, they have the genetic propensity for the hyperoxaluria, you may even want to check their bone density because they could have signs of osteopenia or even osteoporosis. So it can certainly kind of leach minerals from the bones. And our last line there as well, it binds to minerals. We mentioned the calcium, which is what leads to the buildup of those deposits, but it can also bind to magnesium and zinc. So you want to make sure that you're checking those levels as well. And the key with that is you want to make sure that you're looking at ionized calcium. It can be difficult to calculate this, but there are ways that you can test for it and different calculators that are available thanks to the internet. Yes, it's a handy tool. And then, of course, it can also be deposited in the soft tissue. Michelle mentioned a little bit about autism spectrum disorder. We see a lot of kids, especially with the eye poking behavior, when that's actually oxalate crystals that have accumulated within the eye tissue. And then, of course, fibromyalgia, which I feel is becoming more and more common. A lot of times it's because that muscle or joint pain that people are experiencing because of these oxalate crystals.
Absolutely. So one thing that I want to mention here in terms of osteoporosis. So, a DEXA scan is something that looks and measures and tells you whether or not you have osteoporosis or osteopenia, which is, almost having osteoporosis for those of you who aren't familiar with that condition. It looks and tells you whether or not you have it. It doesn't tell you whether or not you have active disease. And so when we're looking at, the process of bone destruction, which is, when we're looking at oxalates, this is a active leaching of calcium out of the bones. Okay, so it's binding those minerals. It'd be kind of important to know whether or not it's happening right now or whether or not the bone destruction happened 10 years ago. Okay, so there's a marker called collagen cross talopeptide. And so this is something, it's a urinary test. Oftentimes we use this test when we're getting bisphosphonates or drugs that are supposed to help with osteoporosis. But you can use this urinary test and actually measure whether or not we have active bone destruction or active bone loss. So for my biologist or my doctors, looking at osteoblasts, which build tissue, or osteoclasts, which destroy it. We have active bone remodeling that happen all the time. So when we're looking at this process, in terms of whether or not your oxalate diet, your low oxalate diet is working, and whether or not you should be supplementing with calcium or not, this is an important test to be looking at. So these are really, really important things, and not a test that everybody's really familiar with. So those are things that you should be looking at. So DEXA scan, yes, very important. Find out if you have osteopenia or if you have osteoporosis, but then also measure, okay? So look at that ionized calcium, because that's super important, but then also take the next step and look to see whether or not you have active disease. Because you're not supposed to be able to reverse osteopenia or osteoporosis, but I've had a couple of patients who've gone through the process of, removing the oxalates out of their diet and then being able to actually change those DEXA scores, which is supposedly unheard of. So just food for thought on that.
Love it.
Yeah. All right. So how do we fix it? All right. So what do we do?
All right, so we talked a little bit about this, of course, low oxalate diet, and we really like to make sure that we very, very slowly remove these foods or decrease these foods from the diet. I don't want to say remove, because we'll talk about this in another slide, but there's something called oxalate dumping, which can cause a whole new set of issues as the body kind of finds homeostasis again. Those shifts can cause other symptoms and issues if these foods are removed too quickly. So we look at how many points we want them to have. We usually help them take out the big four first: the nuts, the soy, the wheat, and the spinach. And then we kind of take a look at the other foods in their diet, and of course we can accommodate depending upon their preferences. Magnesium citrate can actually help to dissolve these oxalate crystals when they have started to accumulate, so that can be very helpful. And calcium citrate can help to block the absorption. So this can kind of be taken as a prophylactic almost. If someone is knowing they're going to be consuming a good amount of oxalates and they can't really avoid it, this may help to kind of block that absorption in their body. The good news too in terms of diet is that how you prepare certain foods can actually reduce their oxalate content pretty significantly depending upon the food. So boiling, soaking, those things can help to pull some of that oxalate content out so that you can still enjoy some of your favorite foods and not go over your point or your milligram level depending upon what kind of personality you have. You, of course, want to watch for any kind of issues with digestion. A high-fat diet with bile deficiency can actually increase the absorption of the oxalates, so that can cause issues as well. We want to look at the gut. And then lastly, remember, AGT has the cofactor of P5P, so we want to make sure that we are looking at that and possibly including that within the protocol.
So who wants to talk to me about why calcium citrate might be problematic long-term?
So there's a risk of calcium depositing in heart tissue. Is that correct? Yeah.
Right. Right. So we want to make sure that we are, balancing. So this is why a lot of supplements have calcium and magnesium together. So you see like a CalMag supplement. The other thing that we have to make sure we're taking calcium, so we've got to make sure that we are managing the system here. So we've got, calcium, magnesium, vitamin D, and vitamin K. Okay, so, this is one of those things where a lot of people, we would tell them to take, if you're going to be out at a party or an event or something like that, or if you're traveling and you know that your only option is to eat a high oxalate meal, that's really when you want to take calcium citrate. So, these are the kinds of things where, you're going to focus in on that because it's really going to help you block that absorption. Now, if you don't have a risk of cardiovascular disease and you actually do have low calcium levels, so, a lot of times we see high calcium levels in the blood. Sometimes we see low calcium levels in the blood. So Laura, do you want to talk about this a little bit? We were talking about this a little bit before. So you want to talk about this, or you want me to talk about this a little bit?
I can start. And partly because it's what I tend to see with patients. And so it always, if I see the blood work prior to talking with people, I'm able to sort of look at that as one of those markers and be like, oh, this is a question I should ask. So either high levels of calcium in the blood or low levels of calcium in the blood. And so we were sort of just talking about, what's causing that whole issue. And so when we're looking at high levels of calcium in the blood, a lot of times that means that the bones are actually leaching out calcium that's being drawn out into the bloodstream so that it can help bind the crystals, or the oxalates. And then, so there's active destruction. And that's when we were talking about the difference between the two tests and why that's important. And then the lower calcium is likely because you're, at that point somewhat deficient, that whole process has happened and the calcium's being bound. And now we're at a deficit. So it's, again, it's just where you are in that whole process. And so for me, it's always important for me to be like, oh, that's what could potentially be happening. So I'm going to ask that question and see if we can figure out if this is, or do the testing, the follow-up testing that would help us look at oxalate issues.
Exactly. So, if people have low levels of calcium, so hypocalcemia, a lot of times they're going to have numbness and tingling, most often around their mouth and their nose. So that's going to be like the first sort of thing people are going to talk about. Sometimes they're going to have numbness and tingling in their fingers and toes as well. So they might present with neuropathy, which might be a little bit confusing to a practitioner trying to kind of figure this out. So if you have somebody that has fibromyalgia and then also says that they have Raynaud's, or that they have, they feel like they have stocking and gloves on their feet or their hands, this might be something that you go, maybe I should check their calcium levels. Maybe I need to be looking at that. So, these are all things to be thinking about in terms of how an oxalate, issue may present. Of course, when we're talking about things like kidney stones, a lot of times for women, milder presentation is going to present with chronic UTIs, interstitial cystitis, feeling like they have sterile UTIs or having sterile UTIs. They don't actually have infections, but these little grains of oxalates are going to be, present in their urine. So if you look and do a regular, urinalysis with sedimentation, you're actually going to find these little oxalate crystals in their urine. So, and for those of you doing functional testing, if you find low levels of citrate on an organic acids test, this means that they have a higher risk of having stones or likelihood of hyperoxaluria. So there are several things that you can do as a clinician or as a patient to kind of go, man, maybe this is an oxalate issue, and that it's not necessarily what the condition is that you are expecting it to be. Maybe it's not interstitial cystitis, that you've got a chronic infection in there. Maybe it has something to do with your diet. So food for thought on all of that.
Before we leave we leave the slide really quick, we skipped over the vitamin C. I just wanted to say one of my most profound cases was someone who was taking 6,000 to 7,000 to 8,000 milligrams of vitamin C daily for her immune system for over 10 years. She was the one with the buildup of calcium in her shoulders, where every time she ate, she could feel pain. Mm-hmm. And she had hyperoxaluria type 1, 2, and 3. So when we got out the vitamin C, I was reading notes she had from her doctor. Her pain went from 10 to 2. So, I mean, it's a pretty profound. I mean, vitamin C is a wonderful nutrient, and we definitely need it. But people who have these issues should not be over supplementing with vitamin C. This is not a thing. I hear practitioners telling people to take 1,000 milligrams every hour when they're sick. I mean, maybe one dose to help, one dose here and there, but people who have these genes, they just cannot do it. So you really need to know your genetic status before you are doing high doses of anything, period. You need to know your biochemistry.
Especially if you have any kind of health issue. I think that's the thing is that, if you're walking around and you've got nothing wrong with you, and, you're, 70 and spry and, no history of cancer and, everything feels wonderful and nothing's wrong, then, sure, go forth and do, but, I think that it's, a lot of people, they just don't make the connection. That they, that their biochemistry and their genetics are actually having, and their diet are really playing such a dramatic role
and the supplements they're taking.
And their supplements,
they're
right?
taking a lot of supplements, and they don't realize that each supplement is causing a biochemical effect in your body, and they all interconnect. So you got to start with one or two things,
Right.
and you know, it's just
they're medications. Ultimately, supplements it's medication, and it
Yeah.
should be treated as such.
Mm-hmm.
To your point too about people who, you know, have something going on with them, one of the things I've noticed with this too is, and I know we're going to get to the fluoroquinolone stuff a little later, but you know, I had somebody who had pneumonia, has EDS, so Ehlers-Danlos, so connective tissue. They had Cipro, I believe, and they were taking huge amounts of vitamin C because they had pneumonia. So, you know, they were assuming that was going to help them not get a reinfection. And so, of course, you know, there's the cascade of effects, you know, that happened there. And here they are, they have this issue. And so it definitely matters. It matters a lot.
It matters a whole lot. And, you know, I mean, I can't fault everyone for not being a biochemist. You know, I mean, there's not that many crazy people out there like me who want to do that. So, I mean, I fully take responsibility for my wackiness. But, you know, it's knowing that part is such a game changer in terms of therapeutics. And so if every doctor could be a biochemist, that would make me a happy person. That's one of the things I'm trying to do with Omics, is make that available. So that they don't have to be biochemists, but they have the benefit of being a biochemist. So that this kind of information becomes at hand and easy to access.
Great.
All right, so oxalate dumping. Don't be fooled by the honeymoon phase, because God knows we all are. All right, so what happens when we dramatically remove all of the oxalate foods? So Michelle, the person you were talking about that had the oxalate crystals in the shoulder, didn't she take out all of her oxalate?
You know, you heard what I said and just stopped the vitamin C cold turkey, all the nuts, everything. And she felt okay. She used to juice a lot. So when she would do a week-long juice fast, she actually felt better because she wasn't eating all the nuts and all that stuff. So even though she had spinach going on there, it was still lower. But then she would start eating again. So she never had the oxalate dumping. But this time she took it all out. And she actually is not a medicine taker. She took Advil for 3 weeks because it was so bad, with the oxalate crystals actually coming out of the tissue. And then you guys can talk about the homeostasis, because I'm not good at that whole thing. But when the body starts to rebalance, you start having just painful symptoms. So she did do that. So don't do it all at once. Work with us to do it slowly, and then it will work really well.
So but she had 3 weeks of just extraordinary pain. Did she have any GI symptoms or anything? Or just
GI symptoms? Yes, GI symptoms, diarrhea. She had, I mean, anything you could think of. She was actually out of the country at the time, texting me like, I said, you just take the Advil. You've done it. I mean, I can't.
You gone and done it now.
No looking back.
So what happens is that, so if you're eating a lot of oxalates, okay, and so without getting really complicated here, they're ions, okay, so calcium is a +2, okay, so you've got this gradient within the body, and if you've got calcium within the bone and you've got oxalate on the outside, it's trying to keep this balance, but you've basically flooded the one side, and so it's trying to pull the calcium out, okay? So you've got this imbalance system going on here where it's basically sucking the calcium out of your bone, okay? So, and also other minerals too, okay? So the oxalates are, basically they're too high, and so it's causing this imbalance. And then all of a sudden, if the oxalates go away, whoop, it does this, okay? So I've got to make sure my hands are in the picture here. So all of a sudden it flips the other way. All right, so this can cause, not only an uncomfortable sort of electrolyte imbalance in the body, people feel woozy, they don't feel good, but, when we're talking about, balancing things like zinc and magnesium and calcium and all of these things, we're going to have a sudden shift in the mineral content in the bone, but then all of a sudden it's going to eject all of those oxalates. So think about oxalate crystals. Shards of glass, remember guys, really painful. And Laura kind of describes it as like scraping out of your system, you know, like it's scratching its way out. I mean, this is painful. That's what it feels like, okay? So, I mean, this is not a fun sort of thing. And so, yeah, so some people are of the mind, they're like, I'm going to get this over with. Like, let's just do it, and let's do the 3 weeks or 4 weeks of, you know, I'm going to drag myself up with Advil and have this massive inflammatory process. And if you're relatively healthy, I'm not suggesting that you do this. But, you know, some people are like, forget it. I'm in, I'm doing it, I'm out. And you're going to have those people that are going to be like, okay, fine, I'm in it. I'm going to do it. I'm going to go to Bali for a month, and I'm going to have this out. And if you can do that, then fine. I still don't recommend that, but if that's your predisposition, then okay. But generally speaking, we do it over 6 or 8 weeks, where we slowly reduce the oxalate content in your diet so that you have a gradual reduction in oxalates, a gradual shift in terms of your electrolyte balance, so that you do not have this massive dumping process, and it's safer this way, okay? Because we do not want to have massive swings in calcium in your body. Again, this is a major ion in your body. This is something that can cause you to have all kinds of issues in terms of cardiac response, all kinds of things. So you have to be super, super careful in the way that you are rebalancing your minerals in your body. All right, so lesson, remove very, very slowly. If you are oxalate dumping, sometimes you will have cloudy urine. You might have sandy looking stools. Yay, fun, where do we sign up for that? A lot of times people will have, I know you guys all laugh at me, sometimes you're gonna have varying degrees of constipation and diarrhea. Sometimes you're gonna have rashes. Migraines are really, really common. Again, those oxalate crystals are sucking themselves out of your brain, okay? Fun, right? Again, where do I sign? Now remember, magnesium citrate and calcium citrate, these things are binding more oxalates. So should you be doing a lot of this? So if you have a chronic history of constipation, which by the way, if you have oxalate sensitivity, you're almost always gonna have a history of constipation. Okay, you're gonna be the person that goes, I've been constipated since I was 5 and I've never been able to poop. Okay, that's gonna be the person that tells you, you're gonna know off the top of your head that you have an oxalate issue, okay? Because remember, oxalate crystals, they pierce your GI system, they cause inflammation. You're gonna be constipated for 5 or 6 days, then you might have 1 day of diarrhea, and then you're constipated again. Remember, your GI tube is a tube, okay? If it gets inflamed, there's nowhere else for it to go but down, okay? That's why you can't poop. Just saying. Okay, so anyway, not a good idea to take more magnesium citrate or calcium citrate during your oxalate dumping period if you're actually oxalate dumping, which if you're working with a trained professional like a CNS, you won't. All right, now here's the fun part. Promised you I would talk about something fun here, fun. Fun for our biohackers. Now, without getting really overwhelmed here, okay, this enzyme here is called proline dehydrogenase, all right? Proline is something that's part of collagen, okay? So if you're thinking about collagen powder, if you're also thinking about our building blocks within our system, okay, collagen is literally part of all of your connective tissue. This enzyme is a glutamate something or other. Think about glutamate, MSG, monosodium, I can't talk, monosodium glutamate. So neurotoxin, okay? So something excitatory in the brain. This one's also a glutamate over here. This one is pyruvate. This is our main energy substrate in the body, okay? So we've got a collagen something over here, an excitatory something over here, an energy substrate over here, and then we have our enzymes here that are making oxalates, okay? So glycine, this is our enzyme that we talked about earlier. This is genetic hyperoxaluria 1. And then these are some other ones, okay, that are associated with our oxalate pathway, okay? So without really getting too complicated, what I really want to talk about, and for those of you who are clinicians or biochemists in here, the problem here is that when we have excessive breakdown of collagen, which is essentially what's happening here, if we're breaking this down either through genetics or through things like fluoroquinolones, so fluoroquinolones like Cipro or Levaquin, they attack type 1 collagen. Okay, so if they attack type 1 collagen, they're basically going to push this pathway. Okay, so they're going to make more of this go. Okay, so if we make more of this go, we're basically going to have neurotoxicity. We're going to have more glutamate in the system. Okay, so your brain's going to be on fire. You're going to have a lot of anxiety. You're not going to feel very good. And then we're going to have some energy metabolism issues. Okay, so we might have some fatigue issues because we're not controlling our energy metabolism very well. And we're going to make a whole bunch of oxalate. Okay, so when we're thinking about this in terms of whether or not people with connective tissue disease should consume oxalates, this should make you pause a lot. If you're thinking about those of people who have fluoroquinolone toxicity or damage from fluoroquinolones, should they be eating oxalates? The answer is no. Okay, so people with Ehlers-Danlos syndrome, people who have fluoroquinolone toxicity, people with multiple sclerosis, people with lupus, people that have any sort of malfunction in the way that their collagen tissue is put together should really think long and hard about the fact that their body has impairment in the way that they process collagen, essentially. It's going to increase their glutamate levels and cause deposition of oxalate in the tissue. Now, for those of you who like collagen powders, you're essentially upregulating this pathway as well, okay? So food for thought on that, okay? So if you have impairment in the way that your body processes oxalates, if you are consuming lots of collagen powder and all of a sudden you feel anxious, this might be why. If you consume collagen powder and you think, hey man, this is supposed to make my body feel good, and you feel worse, you might have an oxalate issue. Okay? So food for thought, might be a little heavy on the biochemistry, but for our biohackers that might enjoy this, that was a little treat. Now, we do have this and several of our other genes that we talk about on GeneBites and our optimal diet package and our optimal diet panel. I might turn this over to Michelle for a second to talk about our optimal diet panel a little bit more. Yeah.
Our optimal diet panel is amazing. It's off the chart amazing. It's completely different than the ones you're going to see every single day. I've got ads popping up on Facebook about, does your body like caffeine? Does your body like blah, blah, blah? We look at all that, but we are looking at things that you can actually change in your diet and in your nutrients. And we teach you to know your unique biochemistry. We're looking at your metabolomics in your labs to confirm that these genes actually matter or they're active in your unique body. Because just because you have a SNP or a gene variation doesn't mean that it's actually doing anything. So just because you have MTHFR doesn't mean you need to take folate. You have to look at the whole huge biochemical pathway. Things way over here are affecting that one gene. So but in this specific panel, we are looking at what we talked about last week, sulfur metabolism. We're looking at your oxalate metabolism. We're looking at how you process nutrients. We're looking at things like, should you be eating gluten? Because there are the HLA genes, but there are a bunch of other genes that might make you more susceptible to have non-gluten intolerance, or what is that called? And non-celiac gluten intolerance. We look at how you process lactose. We look at if you have the genes to have hemochromatosis, which even if you don't have hemochromatosis, you may have other iron issues. We can adjust your diet for that. If you need more iron, we can add citrus to when you're eating red meat, if you, stuff like that. What else is on there? We've got
fatty acid desaturase gene.
Help me out here.
Yeah, we've got fatty acid desaturase gene.
Oh my gosh, the fat metabolism is huge. We look at, ketogenic diet is super popular, but there are certain genes that you really need to be looking at before you do it long term. We can be creating mitochondrial dysfunction. Saturated fat can be causing all kinds of issues in your body if you have specific gene variations that we look at. And we're running, again, metabolomics that will look to tell you exactly how that gene's working in your body. So it's amazing, it's life-changing, and it will really help you get to know yourself. It's like me having a crystal ball and telling you exactly why you are the way you are.
Yeah, it's fantastic.
I'm a fan.
We look at over 350 variants on the optimal diet panel. So shameless plug, we're doing a sale right now on the mini panel, on the mini Diet DX. So if you want an appointment with any of my team members here, you can actually sample a free mini Diet DX for the month of January. So if you guys have any questions, please let us know. And thank you for joining us today on GeneBites. We will see you guys in February, and we look forward to seeing you guys then. So take care, and we will see you guys soon. Bye.